report. We have two scenes. We've got the hospital, we've got the house. We do the reenactment, but despite all that, medical records, everything, the cause of death, sudden unexplained infant death with bed sharing. Manner of death has to be undetermined. Okay, so talked about the autopsy is completely negative. Scenario suggests asphyxia, right? We're all in our guts think, and probably that this mom rolled or dad rolled over on the baby, right? There's, or could even just have been face down in the bedding, for all we know. Could it be some undetectable natural disease that poof struck this baby while that baby happened to be sleeping in an unsafe sleep environment? It's possible. I acknowledge that that's possible. If we're on a scale of likelihood, rolling over on top of the baby and smothering versus some natural disease that poof happened to occur on that night, I'm like this. This one isn't 0, and this one's not 100, but it's kind of close. So I definitely cannot call that sudden infant death syndrome and the manner of death natural. That's a misleading statement to the parents, because then they're going to think, oh my goodness, it just happened. There's nothing I could have done about it. Let's put the next baby in bed with us. Okay, what happens in the unsafe sleep environment? There's the theory of rebreathing. So this is just the fluffy bedding, pillows and stuff like that, where the baby on his or her stomach. Even though the head may be turned to the side, this is also the theory with the bumpers around the crib. And we'll kind of have a confined space. It's open to the environment, but it's kind of a pocket in the bedding. And the baby is inhaling whatever oxygen is in that pocket and exhaling carbon dioxide into that pocket, and eventually runs out of oxygen, and all that's left is carbon dioxide, and the baby suffocates in that manner, even though there's no occlusion of the airway. Right, then of course there's just straight up occlusion of the airway by the fluffy pillow or the dad or whatever. And then there's strangulation with all kinds of pacifier strings and the blind cords and all that sort of stuff, right, strangulating the baby. There's the rollover asphyxia, there's choking, leaving the bottle, propping up the bottle so the baby can go to sleep. The wedging with some of the wedges, or rolling off the bed and becoming wedged between the bed and the wall. Been to that scene with the crib right next to the bed. And then many other possibilities, that, you know, endless possibilities. So regarding rollover asphyxia, this is, I think, one of the key points to take is what's going on with the parents or the co-sleeper, the bed sharer. I think that there are probably 4 patterns that emerge from this. There may be more, but one is that the adult rolls over onto the baby, right, while asleep, wakes up on top of the baby. Oh my gosh, what have I done? Calls EMS, tells EMS as they're running in the door, I was on the baby and I think I suffocated, whatever, tells the police, tells the medical investigators, everybody, this is what happened, right? So I know the cause of death is asphyxia and then the manner of death is an accident. Another is that the adult rolls over onto the baby, wakes up on top of the baby, thinks, oh my gosh, what have I done? Calls EMS, calls police, will never admit it because they're afraid that they're going to go out in handcuffs. Right? So that's a bit of a shame. Because I think 99.9% of all the jurisdictions would never prosecute somebody for something like that. But you can understand why parents would be terrified of that, right? So they intentionally lie about it. The other is that they wake up on top of the baby, and those of you who have any insight into the psychology of the human mind, we have defense mechanisms, right? That's why prisoners of war are amnestic about their time, or rape victims often can't recall what happened, right? Because we block that out, and thank God for it so that we can move on with our lives. And so perhaps these parents will block this out. Oh, no, 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 no. No, I didn't see that. I didn't see that. You know, and they believe that this didn't happen. They can modify it, and they'll believe their modified story of what happened. And they'll probably pass lie detector test, right? And there's nothing I can do or say to them to get them to say, like, oh yeah, you know what, you're right. I did roll over on the baby. And then, of course, the fourth and probably the most common scenario is that I roll over on top of my baby and sleep. The baby dies. I roll off of the baby, still asleep. 1, 2, 5, 30, 60 minutes go by, 3 hours go by, whatever. Then I wake up when my alarm clock goes off and I find a cold, deceased baby next to me. And the baby's still face up. There's no blanket covering the face. There's no pillow. I'm convinced that this is still the same environment that I put the baby in when I went to sleep, and it must be SIDS. So here's an example of a reenactment. And this was how the baby was found. So I didn't put the placed photo where the baby was obviously not covered by the pillows when the dad put him there, or her. But then dad goes to sleep, and when he wakes up, he finds the baby like this with the pillow over the face. Now, I could give them the benefit of the doubt, and usually I do, and say accident if the father presents this scenario to me. There's really nothing to suggest that he didn't take the pillow and put it over the baby's face himself. So we can't call these natural. That's drastically misleading. Okay, so there are plenty of people out here. This is one of our obstacles. Many bed sharing promoters, including these guys here at Notre Dame, Northwestern University, highly educated people. Never sleep with baby, or keep me close, but keep me safe. Eliminating inappropriate safe infant sleep rhetoric in the United States, right? You use the word rhetoric, and that's bad. You can't use rhetoric, you know. Reading this information, there are amazingly difficult guidelines to comply with. How to have a safe bed sharing environment. And it really sounds a whole lot like the environment you should put your baby in the crib. Okay, so be sure you have a firm adult mattress without the pillow top. Only a fitted sheet. Put your baby there. No pillows anywhere around. Don't let them fall off the side of the bed, this and that. No blankets or whatever. It's the exact same environment we recommend in the crib, except for on the same surface with you. So I challenge you to say that the type of parent who is going to put the baby in the bed with him or her is probably not the type of parent who's going to take every sheet and blanket and pillow off of his bed, right? And get rid of the pillow top. Probably not that parent. If you're the type of parent who is willing to have that kind of sleep environment where you're lying there in bed with only a flat sheet and no pillow, no blankets, no nothing, you're probably the type of parent who would put the baby in a crib, right? I mean, if you're going to go through all the troubles of having that kind of sleep environment on your adult bed, then you would probably just be like, forget this, I want my down comforter, I'm going to put the kid in the crib. So these are kind of mutually exclusive categories that we're talking about here. Anyways, the point is there's almost no way anybody's going to go through all this kind of stuff. Safe bed sharing conditions. This is one of my favorites. When you're sharing your bed with your baby, be sure you don't do it when you're medicated or you've been drinking. If you've got children of your own, I've got 4 of them. I spent 3 semesters at Tulane in New Orleans before I went to UT Arlington. I came to my senses and quit blowing so much money at Tulane at $35,000 a year. And I enjoyed myself on Bourbon Street. I never got as sleepy and drowsy when I was a 21-year-old on Bourbon Street as I've been with a 4-month-old at home while I've got a 2-year-old and a 6-year-old, right? I mean, I've never been that tired. So don't give me this. Anybody who's got a kid at home is as tired as they could possibly be when they were drunk, right? So by default, if you've got an infant, you are that level of impaired. Okay, what is an unsafe sleep environment? If it's not a crib with the good narrow slats, right, properly assembled with all the screws tightened, away from a window, right, on a blank wall with no blinds around, in a comfortable room, it's a good environment. You would feel comfortable sleeping here, then the baby would too. With only a firm baby crib mattress and a fitted sheet, and the baby's in a sleep sack, if it's not that, then it's not safe. Anything other than that is not safe. The pacifier in is fine, that kind of thing, but no string attached to it, right? No pillow, no wedge to keep the baby over on her side, none of this stuff. The baby's on his or her back. not on the belly, right? No blankets in there with the baby. These things turn into ligatures as they get twisted and wrap around the neck, right? There's probably a low likelihood that your very thin little wispy blanket is going to be so heavy that it suffocates the baby. But these things get twisted into strings, ropes, and then they manage their way around the necks. The only thing in there is the baby. All right. It's critical that we provide a consistent, repetitive message. Right? We've got to do this every single time on every single baby. There's no days off. Right? So this is going to be your hospital-based program. This is what you guys are going to be working towards. This is what your hospital is working hard to achieve. Some hospitals already have this certification, right? And you guys are going to prove that you can meet the standard and that you can educate patients, right? We're willing to look this problem in the eye, right? We're not going to be in denial about it. We're not going to worry about hurting people's feelings, right? We're not going to worry about offending someone's cultural practice, someone's preference, right? That's fine and dandy. We've got to be sensitive to that kind of stuff. But we're talking about the life of the child. And so we've got to take that in our hands and take it as our own responsibility. We wouldn't let them smoke in the room with the baby. We wouldn't let them. I delivered a baby here. I had to have prove that I had the car seat before I could even leave the hospital, right? And thank God for it. So you would do that, but you know, are you willing to have a conversation with them about where is the baby sleeping? Are you willing to prove to them that the baby doesn't lie in the bed with the mom? Of course, while nursing, one of my kids, and I don't think it was the one I delivered here, I think it was one that I delivered in Dallas, I had a nurse recommend that we keep the baby and let the baby sleep in the bed with us. Oh no. She didn't know who she was talking to. That did not go over well. So, you know, are you willing, if that's the way that you've practiced before, are you willing to change that? You know, and we all know that we do influence our patients. We give them the guidelines by which they're going to live their lives, right? Through our words, but also through our actions. So the goal is going to be kind of along the lines of the Back to Sleep campaign, right? The results, by the way, the results of the Back to Sleep campaign, that success only due to the simple act of turning babies from their bellies to their backs, well, that probably had a huge influence. But I'll challenge you again to think the type of parent who is going to take the time and ensure that their baby is on his or her back is probably also the type of parent who is going to get all the junk out of the crib, who's going to put a fitted sheet on there, who's going to keep the baby in the crib, right? So no mistake that switching from belly to back helps, but all those other things that went along with that campaign helped also. And so we're going to build on that momentum. We're going to identify that specific problem along with Back to Sleep and reiterate it every single time, every encounter. So this is it, right? This is the pack and play version. That's it. Baby, sleep sack, the little mattress in the pack and play, nothing else. And this is away from the window and all that other kind of stuff. Oh, this is my baby's mattress. Okay, my youngest now is about 20 months old. And he, just this past weekend, he woke up and his diaper had exploded all over the place. You know, those crystals were everywhere. So I had to swap the sheet out. And as I was putting the sheet back on, I thought, oh, I need to take a picture for the presentation. You know those little bungee things that you put on your adult mattress over the corners to keep the sheet from popping up because that's so annoying? My wife and I had the idea because one of our kids would always pull this fitted sheet off. I don't know how he did it. He was also the kid who always took his diaper off in the middle of the night, and that was always a problem. So we thought, oh, we came across these one time at like Bed Bath & Beyond, and just put them across here. And of course, that's on the bottom of the crib, right? And it solved that problem. So this certainly is no official recommendation from any academy or even from me, but it's an idea to keep that fitted sheet from springing loose because that's obviously a danger in and of itself. So recommendations for a safe sleep environment, right? We've got to talk about it being evidence-based. It's enough to be anecdotal. but we got to have our evidence, right? Back to sleep for every sleeping encounter. Hands down, that's ironclad. That's decided. Use a firm sleep surface, right? Room sharing is recommended without bed sharing, right? Big difference. Now, again, remind you, some people use the term co-sleeping and they mean room sharing, right? And then other people use the term co-sleeping and they mean bed sharing. So always ask, somebody mentions co-sleeping, the next question is, what do you mean, bed sharing or room sharing? Keep soft objects, loose bedding out of the crib, and of course, pregnant women should receive regular prenatal care, right? That goes without saying. Now that's one of those to reduce the risk of SIDS recommendations. Well, of course, we're talking about SIDS kind of equaling unsafe sleep environment so many times. So then if it's a recommendation for reducing SIDS, it's also a recommendation for reducing co-sleeping bed sharing deaths. Breastfeeding is recommended, right? That makes, generally makes healthier babies and promotes that maternal-infant bond. And if you are breastfeeding and you've got your bond developed that way, an activity you're doing while you're awake, theoretically that should eliminate one of the other quote-unquote benefits of bed sharing, which is the maternal-infant bond. These bed sharing promoters, one thing they cite is that they want the mother and the infant to bond. And if you're breastfeeding, then that increases your bond and decreases your need to share your bed. The pacifier at nap time and bedtime, again, no strings. If it falls out, leave it out, that's all fine. But going to bed with it is fine. A comfortable environment that you would be willing to sleep in and feel comfortable in. You don't need any of those monitors. So a lot of times they get in the way and actually cause at least as many problems as they would solve. If you've got the baby in his or her crib in your room with you, you're hearing those things and you don't need that kind of monitor. And then this is where Ms. Carroll's going to expand and give you all the information about getting the campaign going. It's a national campaign, right? Like many other national campaigns and blue magnet certifications and all these kinds of things where there are criteria on the checklist that you check off. Do you want to take over and talk about that now?
Emphasis on the national campaign includes the emphasis on SIDS risk reduction, focus on the education regarding safe sleep environment and strategies to reduce the risks of all sleep-related infant deaths, including SIDS, suffocation, and then other accidental deaths. Who are our participants? We are. The pediatricians, family physicians, family primary care providers, really anybody that has anything to do with taking care of kids. So that's really even our ERs, our physicians in our ERs, our staff in the ERs. Public education, all caregivers is going to receive education. So a hospital-based, infant-based safe sleep program, there are several that are out there. How can we accomplish this? By providing accurate and consistent infant safe sleep information to all of our personnel. So this includes even the nutrition person that's coming in and finds a mom in a recliner with their baby and that's asleep. Do we expect that nutrition person to go and do that and to take the baby away from the mom? No, but we do expect them to go to the nurse and report this, or even to call the bell and have them come into the room at that point. Implementation of modeling of safe sleep practices throughout the Methodist healthcare facility. How many of y'all work on PD? How many of y'all are used to letting parents sleep in the bed or have them sign waivers? So again, this is a practice that has just got to stop. We want to provide direction to healthcare providers and professionals to ensure that safe sleep education for parents is consistent and repetitive. So this might involve scripting so that we make sure that we're telling everybody the same thing. The plan, develop a policy. It is currently in review, and I want to thank Arlene for helping me write this policy because it's been kind of challenging. We're hopefully anticipating that it's going to be approved in the next month or so. Program acceptance. So we've got to have everybody buy in. We've got to have administration, which is supporting us. We have to have the staff buy in. Our targeted go-live date is tentatively set for May 15th. Our safe sleep education for our staff, we're going to have a link on HealthStream. The course that we're going to do, and I have done it myself, and it's an excellent course, is the Curriculum for Nurses. It is basically the NIH's risk reduction for SIDS and other sleep-related causes of infant death. And we're planning on, we will start assigning that March 21st to the staff members. How are we going to do this? Obviously, I can't go around to all the hospitals and teach this, nor can I expect any of y'all. So we're going to basically use our safety champions on each unit as the point of contact for reinforcement of safe sleep education and the coaching of staff, because we do know that we're going to come across barriers with parents, and by anticipating that, it will make the transition much easier, I think. Continuing on with the plan, safe sleep education for our parents and guardians. So basically this involves them watching a video. The video is the same one that the NICU and the nursery staff do watch already. It's a 10-minute video. It does come in English and Spanish. We do have the ability to put it on the hospital television, so that is something that can be done in the hospital room when you are actually maybe admitting your child to your unit. Have the parent watch that so that they know what the practice will be. Make sure that we discuss this upon admission, what we do practice as far as safe sleep practices. So we need to make sure that we do have a safe space for the mom and a safe space for the baby. Our Safe Sleep for Your Baby pamphlet is our pamphlet that's going to be on the table. It's going to be imprinted with our logo. This is what we're going to give out when the patients are discharged. It also will be mirrored to what we have in Meditech as well. So the challenge here, if the baby is found in an unsafe sleep environment, following is the staff expectation. So we're going to make sure that we return the child to the safe sleeping environment is our first priority. We want to provide education on safe sleeping practices to the parent and fall precautions, because if they truly are in like an adult bed and that child in their side rails, then they're at risk for falling, in addition to being entrapped or smothering. So make sure we provide that education to them, again, documented in Meditech. You want to notify the charge nurse and the nurse administrator and determine at that point what our safest alternative is for our patient. I do anticipate that we might have people that are blatantly non-compliant. I mean, I hope that that would not be true, but I do understand that people are people, and we will anticipate this, and we will just do our best to address those issues as we come across them. As far as implementation barriers, again, I think the fact that if we can come up with safe sleep practicing scripts, it will help the staff become more comfortable with this process. Parents' compliance, which we'll discuss a little bit further on in our presentation. Safe sleep future activities, this is what's exciting, even though I don't know what you would consider audits as far as being exciting, but we will audit for compliance. We are going to apply for the designation as a certified safe sleep hospital. How many of y'all know if there are any safe sleep hospitals in Texas? Huh? Which one? CMC? Okay. There are different types of levels. The picture up there is actually of the bronze level. The requirements to do a bronze level basically is establish a policy, provide staff training, and make sure that we're educating our parents and our caregivers on what safe sleep practices are. And then basically another exciting thing that we can expect is the incorporation of halos, sleep sacks as a standard of practice, and that is going to start pretty soon, especially in our small baby areas. And we hope to probably incorporate this onto the PD side, and but as far as the ERs, I don't know if it'll make it that far, but who knows. Okay, some of our parental compliance barriers. Some of our challenges are cultural, and again, too, Dr. McClain did mention the fact that some of our barriers are basically culturally based. But a thing that we need to recommend is that infant care often has its roots in tradition and experience. It is not a science. You know, I was of the generation where my kids were put to sleep on their stomach. A little bit as far as statistics, Dr. McClain talked a little bit about this already, about African mothers are 2 times more likely to promote this practice. Bed sharing actually is growing in practice. There's strong cultural influences. Overheating is a significant factor for SIDS in all communities, especially when your child is ill. So again, they're concerned about the fever, but yet they're still putting more and more blankets onto the baby. Pre and postnatal care, again, we do know the statistics show that it reduces the risk of SIDS. And then alcohol consumption, typically within the context of bed sharing. So this again, Dr. McClain is kind of